message. Is that okay?
Your
I'll
order.
just,
Go ahead.
Okay.
yeah.
Seems like it's muted by the host.
We must have done that when there was a noise in the background. Now you're unmuted and you can please begin.
Okay. Specular microscopy is based upon the optical principle of specular reflection. And so when we look at the interpretation of specular microscopy, we have to see that when we look at the image, it is of interpretation quality, which means that we have to see whether the image is analyzable or not. Because it could be that, like, let's say, now this cartoon just explains how the specular imaging works. We have the light source, and it falls upon the endothelial layer, followed by the camera, which shows the specular image or the mosaic of the endothelium. Now, if there's anything in front of the endothelial layer, like let's say on the precorneal tear film or in the stroma, in the form of edema, or if there's a haze on the precorneal tear film, all these things will affect the acquisition of the imaging, as a result of which the image, the interpretation of that specular interpretation microscopy will not be very reliable. So in a way, we have to, when we see a specular image, always we have to check the images of good quality to be analyzed or not, and thereafter do a clinical and a specular correlation. This is one example of a good analyzable image of a 10-year-old. So you can see that the cells are of the cell boundaries are easily seen. So this image is analyzable, and whatever parameters are displayed are accurate parameters as per the image what we see on the specular microscope. Now, similar to what affects the imaging of the endothelial cell layer in Fuchs endothelial dystrophy, because of Gutty formation, there is an interference on the specular image which is acquired through the microscopy, as a result of which the Gutty interfere with the imaging of the endothelial cell layer and hence cause areas of dropout on specular imaging. Now, this kind of dropout area will depend upon the type of Gutty what we see in a given patient, so it will be quite variable. So when we look at specular microscopy in a Fuchs endothelial dystrophy, although it helps in determining the relative extent and nature of the DM alterations of Gutty, it is not always a proxy measure of the endothelial function, because there's no direct correlation between the Gutty what we see and the endothelial function. Now, to explain this, I'll go through some examples. Now, for a Fuchs endothelial dystrophy, our management parameters for surgical decision-making always depends upon the patient's complaints. Tachymetry, which is not just the central, but also a comparison with the mid-peripheral, and the type of subepithelial changes that we see in the subepithelial and the anterior stromal layer. Specular microscopy is helpful only if the images what you procure on specular microscopy are of analyzable grade. And let's see some examples to understand this concept a little better. Now, this was one patient who's a 32-year-old chemistry researcher who had an accidental entry of some chemicals in a lab while doing some experiments. And locally, when she went for a routine checkup following this accident, she was told like there's something wrong in her eye. She had suffered a very trivial injury, not a very major one. Vision was 20/20 in both the eyes. Before this episode, there were nil visual complaints, and the patient had 5 numerous Gutty with pigments on the endothelium, and cornea was compact. There was no subepithelial haze. The pachymetry was in the central cornea was 468 in the right, and the left eye was 470 microns. Now, this is the specular imaging of this patient of the right and left eye. So this is a case of Fuchs with numerous fine Gutty. Specular images in this picture are non-analyzable because we can't see the endothelial cells. Endothelial function, however, is still maintained because the patient does not have any visual complaints. There's no clinical edema, cornea is compact, and epithelial is normal. Now, why I have put this cross on the quantitative parameters is because this report, what we get from the microscope, is not reliable because this imaging was done in the auto mode. This is not reliable because this does not reflect as these cells are, the imaging is of non-analyzable grade. Now, we know that post-cataract surgery decompensation Fuchs endothelial dystrophy, there's a high risk if the cell count is less than 1,000 cells per millimeter square. Now, how do we apply this? And how does specular microscopy help us in determining our plan for the surgical intervention in these patients? Let's say another one patient who is 70-year-old, and she complains of blurred vision. Vision is 20/60 in the right eye, left eye is 20/80. She has cataracts, and the pachy is 572 in the right eye and 562 in the left eye. Corneas are compact with epithelium being normal. This is the imaging of this patient. The right eye shows few dropout areas, few guttae, and the left eye also shows more numerous guttae. Now, this is a case of fuchs with non-confluent guttae. Most of the cells in between the guttae are of normal appearance, and this image, even though because of guttae some areas show a dropout area, this can be analyzed, and this is quite reliable. So in this particular patient, because the cell count is decently good for a 72-year-old, we'll just go ahead with a cataract surgery alone, and no need for surgical intervention in the form of keratoplasty is needed in this patient. A few more examples. This is a patient who is a 53-year-old female. The corneas are compact and the patient has cataract, significant cataract, and you see more numerous guttae here. Now, what about the cells in between the areas of the dropout? The count is 1476, which is like borderline. There's another patient, patient 4, who is 61-year-old female. Corneas are compact, the patient has cataracts, and look at how much of abnormality we see in the endothelial cell there. In both these patients, the cornea is compact, there's no edema, but these patients run a risk of corneal decompensation. So specular microscopy, when it is in the analyzable grade, we can assess like what exactly is required for the patient, whether cataract surgery alone will do or whether the patient requires a combined surgery. So in a case like these two images, we will go ahead with combined surgery along with the cataract surgery. Specular imaging also helps in planning for cases which would be suitable for DSO or DWEK. Now, this is one case where we had a plaque of a descemet membrane thickening, and we see more of pigments in the central cornea. So in the central cornea, the image is non-analyzable because of this reason. However, if you look at the peripheral part of the cornea, by just asking the patient to look down, you can get the specular images from all different mid-peripheral areas, and you can see how much is the endothelial cell density reserve in the periphery. In this patient, the cell density reserve is 2,300, which is pretty okay. As per the guidelines, what is recommended for patients who can go for DSO or DWEK, peripheral clear cornea should at least have an ECD of more than 1,000 cells per millimeter square. So in this specular microscopy gives an idea, even though the central area cannot be analyzed, from the peripheral area, you can determine which cases will be suitable and which cases cannot. Other applications are differential and accurate diagnosis of an endothelial disorder. Now, there are many endothelial disorders which can be confused with Fuchs endothelial dystrophy. Sometimes clear-cut cases of pseudophakic corneal edema get labeled as Fuchs dystrophy, pseudoexfoliation, angle closure glaucoma, chronic uveitis. All these can mimic and can cause corneal decompensation. Specular microscopy will help in making an appropriate diagnosis in these cases. Let's see one example. This is a patient who has a history of decreased vision since 2 months in the right eye. The eye is pseudophaking in both the eyes, and right eye has corneal edema. The right eye pachymetry is 619 microns and left eye is 554. This patient was diagnosed and labeled as Fuchs endothelial dystrophy. Now, when we look at the specular imaging, right eye is not obtainable because obviously there's a corneal edema. Left eye shows a picture like this. There's an increased pleomorphism and there's an increased cell area. Now, this is not Fuchs because we don't see guttae, which are a hallmark feature of Fuchs endothelial dystrophy. This is a clear-cut case of pseudophakic corneal edema. Probably the iatrogenic factors have led to a more rapid cell decline and contributed to corneal edema in the right eye. Another case, this was a case having a poor vision. The right eye has a vision of 2320, left eye is 2020. Both eyes have a primary angle closure glaucoma. The patient has a cataract and the peripheral focal edema. Now, this is again labeled as Fuchs endothelial dystrophy because on the specular imaging, you see dropout areas. Now, quite often, the endothelial pigments are also seen as dropout areas. So it is important to understand what is Fuchs and what is non-Fuchs. A kind of corneal decompensation can occur in post-PI in angle closure glaucoma patients along with pigments, and these need not be confused with Fuchs endothelial dystrophy. Posterior polymorphous corneal dystrophy is by and large one dystrophy which can be unilateral or bilateral. Endothelial imaging in these cases reveals a low endothelial cell count and an increased mean cell area. So it is important to image these patients when we see them in the clinics. This is a patient who was a 25-year-old and shows bilateral involvement in the form of band and vesicles. And if you look at the specular microscopy image from various parts of the cornea, you can see the low cell density and increased mean cell area, which for this age, 770 microns average cell size is not normal. It is much higher than what it's expected to be. This is another patient, a 35-year-old patient who had serpentine band-like pattern and posterior polymorphous dystrophy only in one eye. And many of these patients also have a steep cornea. Sometimes they get just labeled as keratoconus. So it is important to recognize this entity and do a specular microscopy. Also because specifically if you're wanting to plan a cataract surgery in future, it is good to know what is the endothelial cell reserve in these patients. So we can see the right and left eye comparison. Left eye being normal, shows a normal cell count for a 35-year-old, but the right eye being affected by this dystrophy, the cell count is 1,176, which is low compared to what is expected to be from the opposite eye. This was a 32-year-old female with essential iris atrophy variant of IC syndrome. In these patients, very often we see a very normal crystal clear cornea in the center, but most of the changes have happened in the iris and the peripheral cornea. And when we image from different parts of the cornea, we see a picture like this where we see a dark light reversal pattern. And this is quite common to see, and it is very important to image these patients in different gazes to know the extent of involvement and the area of abnormality on the endothelium. Now, for monitoring of the health of the graft, both PK and EK, it is important to do a serial specular microscopy. This helps in knowing how well the graft is doing in the long term. Now, the top pictures show the specular microscopy images of two patients who were 10 years post-DSEC. The top left one shows a count of 1623. Whereas if you look at the right specular image, the cell density is 1020. But look at these endothelial cells. These cells are highly abnormal. They are the average cell size is more, and there's a lot of pleomorphism. Now, the same patient, when they position the patient with a healthy-looking endothelium to have a crystal clear graft, but the one which had increased pleomorphism, this patient landed up in the 11th year with edema, or late donor failure, or the endothelial failure. So, to know the status of the graft, it would be good to monitor the serial endothelial specular microscopy in all grafted patients. What about the relevance in eye banking? The imaging helps in obtaining an objective assessment of the donor health status. Donor cornea allocation for various surgeries depend upon the endothelial cell density guidelines. In general, what is followed and practiced by the eye bank technicians, and this is recommended, is above 2,000 cells per millimeter square are the ones which are suitable for PK graft. About 2,200 is the criteria used for DSEC, and 2,400 cells per millimeter square is usually for the DMEC, because just by virtue of nature of the surgery, these are the rough ECD guidelines followed by the eye banks. Thank you, and any questions are there? I can take them up now.
Thank you, Dr. Sunita.